Welcome to Vascular Interventional Radiology. The purpose of this video is to give you a short introduction to your VIR rotation. So let's go inside. This is the entrance hallway to the VIR suite. On my left, you can see the double doors lead to the procedure rooms. A little further down the hall on my right is the door that leads to the CT scanner that we use for CT guided biopsies. If we continue down the hall, we'll see over here on the right a door that leads into the reading room. And finally, what I consider the most important door in the hallway, the bathroom. In order to get into the conference room, you need to press this button right here. However, that button only works between the hours of 7 a.m. and 5 p.m. If it's outside of those hours, or on the weekends, you'll have to hold your ID up to the black sensor. Now, when you first come to the rotation, your ID may not work on the black sensor, and you may have to ask someone to be added to the list of approved people to be able to enter. Let's go inside. This is the VIR conference room. Hardwood floors, big screen TV, projection screen. Welcome to the big time. The day begins here every morning at 7 a.m. in which we review the cases for the day. This duty will be rotated between each resident and fellow, and you probably end up doing it about once a week. When you are assigned to run the list, you will get the list the day before from the reading room. You'll then research each patient, looking up their past medical history and pertinent labs. And you'll also add the images that are pertinent to the case onto the PACS system to be reviewed the next day when we run the list. There are 3 attendings that are present every day, and they are called the number 1, number 2, and number 3 attending. The number 1 attending is the attending who's responsible for all of the cases that are performed that day, and the list in the morning will be reviewed with the number 1 attending. You may be asking yourself, how will I know what the pertinent information is so I can make my presentation concise but complete? The answer to that is you'll just learn from listening to others run the list. I also recommend that the day before, when you've done researching all the patients, you rehearse the list with an upper-level resident or a fellow, and that way you can make necessary changes before you do it for real the next day. While you run the list, the other residents, fellows, and Nurse Jackie will be sitting at this table and recording pertinent information that needs to be relayed to the nurses and technologists. Why don't we take a look at an example of running the list?
All right, good morning. Why don't we go ahead and get started?
Okay, the first patient is Miss Carolina Blue. She's a 72-year-old female recently diagnosed with breast cancer here for port placement.
Do we know what side her breast cancer is on?
Yeah, it's a right-sided breast cancer.
So let's plan on going left side for the port.
Okay.
Do we have any recent labs on her?
Her platelets are 250,000, but I don't have her INR, and I know that she's been on Coumadin in the past.
Okay. Who's in holding?
I am.
Let's check when she gets to holding whether she's been taking her Coumadin, and then we'll probably need to recheck an INR before she goes back for a procedure to make sure it's okay.
We'll check an INR.
Okay, the second patient is Mr. Ramsey's Tar Heel. He's a 61-year-old male. He comes to us from an outside hospital with a biliary drain. He's here today for a cholangiogram.
Okay. Do we have any kind of imaging on him at all?
No, I couldn't find anything.
Okay. All right. Well, let's make sure that he gets antibiotics before he comes back for his procedure, and we'll see what we see.
I did read, though, in his outside notes that he gets hives when he gets IV contrast.
Okay. Well, let's make sure that we pre-medicate him as well then.
All right, sounds good.
Now let's take a second and talk about what your responsibilities will be each day. There are 3 jobs that will rotate between the residents, fellow, and nurse practitioner Jackie. They are 1. Procedures, in which you will, do procedures. 2. There's holding, in which you will deal with the outpatients before and after their procedures. And 3, there is the inpatient service, in which you will research orders for inpatient procedures and then go to the patient's rooms to get their consent prior to them coming down. You can see what your job is each day by referring to the matrix, which is located in the reading room. Let's go in the reading room and take a look at the matrix on the wall. This is the VIR reading room. As you can see, we have 1, 2, 3 pack stations and a nice shelf to put your coffee on while you're doing procedures. Now, Let's take a look over here at the wall at the matrix that I was referring to earlier. The matrix is actually a fancy name for a schedule. On it, you'll see what your job is each day. It'll also tell you when it's your turn to run the list. Now let's step out into the procedure hallway and we'll talk about hats and shoe covers. You can see at the beginning of the hallway we have a cart that contains gloves, shoe covers, hats, and paper suits designed for people who are not wearing scrubs. In order to enter the hallway, you need to have a hat on. You also either need to be wearing green UNC surgical scrubs or one of these paper suits that we call bunny suits. Shoe covers are not required, but you may want to use them to keep your shoes from getting dirty. Let's put a hat on and walk down the hall. The first thing to see when we walk down the procedure hallway is this board on my right. This board is for inpatient procedure requests. Every time a request is made for a procedure to be done for an inpatient, a blue card is filled out and put on the board. As you can see on this board, we have columns for approved, consult, inpatient, and hold. When the card first comes to the board, it gets placed under the consult column. At that point, the inpatient person for the day will research the card, look up pertinent information on WebSys, as well as look at pertinent imaging, and then we'll present that case to the number one attending for the day. If the attending says that we should do that case, the card will then be moved over to the approved side. The inpatient column is usually reserved for line pulls that need to be done at bedside. And the hold column is for procedures that for some reason cannot go today and need to be put on hold to be done on a future day. And finally at the bottom we have a box for next day procedures. When we have a card that we determine can be done the following day, we put it down in the next day box. Adjacent to the inpatient board, we have paperwork. You'll see the compartments here for blank consents and assessments, and then also for pending consents and completed consents. When you're the inpatient person for the day, it'll be your job to manage this board. This board can occasionally get overwhelming. I have some tips for you to try to manage this board better. The first tip is to triage the cards. In other words, determine which cases have to be done first and which ones are less of a priority. For example, if there is a patient who is bleeding and needs to be embolized, that should become a priority. Or if there is a patient who needs urgent dialysis, that order should be moved to the top of the list. Another important tip is to not try and consent too many patients at one time. Try to do one or two at a time and then come back to the department. This keeps a steady flow of consented cases available if rooms open up, and also keeps the workload from becoming too overwhelming. Also, when you head out to the wards to get consents, you want to plan ahead of time your route so that you don't end up zigzagging across the hospital and wasting valuable time. Lastly, it's important to remember that as the inpatient resident, you need to consent and assess at least 4 cases to be done first thing the next morning before you leave for the day. If there are not enough requests, then obviously this doesn't apply. Also, a first case for the next day should be one that will be able to be done without any issues that could arise overnight. For example, venous catheters for patients who are stable are good first cases. Procedures for patients with low platelets or high INRs that need to be rechecked in the morning are not good first cases. Now let's continue down the hallway, and on the right side we'll see another whiteboard. On this whiteboard we have columns for each of our rooms in which we do procedures. Room 1, Room 2, Room 3, Room 4, the neuro rooms, and Room 8, which belongs to vascular surgery. There's also a column for our CT room. You'll also notice on this board that there are many yellow index cards. On these yellow cards, you'll want to write pertinent information that is told to you by the number one attending during morning rounds. For example, if a portacath is supposed to be on the left, you'll want to write left on the card. Or if a patient's coming in and needs to be medicated prior to the procedure for an allergy to IV contrast, you'll want to write that on the card as well. Now that we've talked about the boards, let's peek into some of the procedure rooms. In the entrance to the control room, you'll see our scrub area. This is where you can get a mask before stepping into a room. In the front of both control rooms, you'll find an area with pegs to hang lead. There's a label that says resident lead, and in that area you'll find lead that you can wear for procedures. In VIR we wear 2-piece lead. The top part is called the vest, and the bottom part is called the skirt. We do this because we get better protection from radiation when we turn our backs during procedures. I'll now demonstrate how to put on your lead. The first step to putting on your lead is putting on your skirt. Now you may want to take your pager off first because it can hurt to have your pager on when you put your skirt on. Now hold your skirt out in front of you and then rotate it so that you can reach behind you and grab the other side with your right hand. Then take the Velcro and fasten it tightly around your hips. You don't want it to slip up and down when you're doing your procedure. The next step is to put on the vest. The vest can be complicated to put on. The first step is to take your left hand and put it through the armhole and bring it up to your shoulder. Then, with your left hand, you'll grab the Velcro tab that is on the right shoulder part of the vest, bring it around your head, and secure it down. Then with your right hand, you're going to reach through the back slit and grab the Velcro from the left side and secure it down in front of you. And then the same thing with the left side. And then finally, you take the thyroid protector and secure it behind your neck. Voila, lead. One final tip about lead. When you start the rotation, I recommend that you discuss with your fellow residents which lead you're going to wear each day. That way you decrease confusion when you go looking for a lead suit prior to going into a procedure. Now, why don't we go ahead and step into one of the rooms. Before you step into a room, you want to be aware about what's going on inside the room. If a surgical tray is open in the room, then you need to wear a mask prior to going in. If there's someone in the room doing a procedure and they're using fluoroscopy, you're going to want to be wearing lead when you go inside. When you are beginning a case, you will want to first get your gloves and open them. Then you can get a gown either from the back table or from the shelf. If you are taking the gown from the table, be very careful not to contaminate the table with your hand. Once you have your gown, you should find an area where you have some space around you. Then you can splay it open and get your arms in the sleeves. At that point, the technologist should come over and tie the back for you. As he or she is doing this, you can start putting on your gloves, taking care not to contaminate them. Once your gloves are on, spin, tie your gown, and approach the table to start the case. The controls for the image intensifier, or II, and the bed are a bit complex at first, but you will learn how to use them with a little practice. When you start out, it's going to be overwhelming to learn all the steps to a given procedure. My recommendation to you is that you read as much as you can about the procedure at home before going in on one. When you are in the room, take that opportunity to ask the attendings, the fellows, the upper level residents, and even the technologists any questions you have about the procedure. Don't forget that the technologists are very knowledgeable about the procedures and the equipment that we use to do them. Remember, when you are done with a procedure, it is very important that you dispose of your sharps appropriately. When you finish with your procedure, you will fill out a procedure note. You will keep the bottom yellow carbon copy to dictate from. If you are scrubbed for a procedure, it is expected that you will attempt the dictation unless the attending says otherwise. You will also sign the nurse's order sheet for the meds that were given for sedation during the procedure. Now that we're done with the procedure, we'll take off our lead and head back to the reading room. In the reading room, you will notice on the wall a box designated for the residents. This is where you can store the yellow carbon copies of the procedure notes during the day. The techs will also put a copy of the PPF for each procedure that a resident is involved in the box. It is important that you try your best to dictate all of your cases before you leave for the day. Also, it is recommended that at the end of each week, you try and clear out this box of all remaining papers. Let's go back outside to the VIR entrance hallway and we'll peek our heads into the CT scanner room. This is VIR room 5 CT scanner. As you can see behind me, we have our CT scanner. It is also equipped to do CT fluoroscopy. In this room, when you're performing a procedure, you want to look down this little hallway into this nook in order to get your gown and your gloves. Now let's take a walk down the hall. We're actually going to leave the VIR suite and we're going to head over to the PRU, or Post-Procedural Recovery Unit, also known as our holding area. Here we are at the entranceway to the PRU. Let's go inside. You'll see in our PRU or holding area that we have many rooms where the patients wait before and after their procedures. When you are assigned to holding for the day, you will do most of your work in this area consenting patients, writing orders, and taking phone calls from patients at home with questions. The first thing you should do when coming in after morning rounds is to make notes on the day's patient list. For example, you will want to write whether a patient who is coming in for a sinogram is going to have a squirt or have to be prepped. A squirt means that we inject contrast through an existing abscess drain and take a few pictures to determine the status of the abscess cavity. For these procedures, no sterile prep or sedation is required. If we are going to exchange the drain or manipulate the existing drain to try and put it more centrally in the abscess cavity, then the tech will need to prep and drape the patient and open a sterile tray. The distinction is important because if the technologist preps a patient for a mere squirt, then time and supplies have been wasted. Also, if the patient is only here for a squirt, then the nurse in holding does not need to start an IV on that patient. The number one attending will tell you whether each sinogram patient will be a squirt or a prep during morning rounds. Other important notes that you will want to put on the day's patient list include if the patient needs antibiotics, labs drawn, or steroid prep for an allergy prior to the procedure. The nurse will look at your notes when the patient arrives and do whatever needs to be done. You will have to sign orders at some point for meds that are given or labs that are drawn. Once the patients start arriving, the nurses will inform you of who needs to be consented and assessed for sedation. They will have paperwork ready for you, and there are clipboards and blue stethoscopes in the boxes outside of many of the draped-off rooms. If you are not extremely behind, it may be helpful to research the patient briefly in WebSys if you do not remember the details from the morning rounds. Talking to the patients about consent may be difficult at first because you will not have seen many of the procedures that you are consenting for. It is important that you take some time at home to read about the common procedures that we do so that you can explain to the best of your ability, step by step, how the procedure is done. Also, you want to be able to realistically describe the risks to the patient. The most important piece of advice I can give you is to ask for help if you feel like you are in over your head. We have all been in your shoes, and we realize it is unrealistic to expect you to know these procedures well enough to answer a lot of patient questions. So if you are stumped, tell the patient that you don't know the answer and need to ask. It may be a little blow to your ego, but not winging it is vital to patient safety. Let's take a look at an example of a consent and assessment. Hi, Ms. Blue. I'm Dr. Isaacson. How are you doing today? Good. I wanted to talk to you a little bit about the procedure that we have planned for you today. Okay. Today you're going to have a portacath placed. Has anyone talked to you about that before?
No.
Okay. So this is a portacath. Okay, this is the port. It'll sit just under your skin in a pocket that we'll make up here in your chest. Okay. So the first step is we give you some medication through your IV, 2 medications. One is going to take away pain and the second one is just going to relax you.
Okay.
Once we have the medication on board, we'll use an ultrasound machine to locate the large vein in your neck, the internal jugular vein. When we found that vein, we'll use some local anesthetic to numb up the skin overlying the vein, and then we'll stick a needle into that vein.
Okay.
All right.
Mm-hmm.
Through that needle, we'll thread a wire that'll go down the vein towards your heart. Once we've verified that it's in the right place in your heart, we'll take the needle off and put a catheter in over that wire just to hold the place. At that point, we move towards your upper chest and we make an incision, like I said, to place the port in. Once we have an incision, we spread the tissue away and create a small pocket. The port will fit snugly in that pocket. After that, we're going to tunnel this catheter part up through the skin to that hole that we made in the vein up at your neck.
Okay.
Once we have it at that same spot where we got into your vein, we'll insert it into the vein over the wire and make sure that on x-ray it's sitting in the right position in the heart. At that point, all we have to do is sew you up and then you're all set.
Okay.
All right. Do you have any questions?
None that I can think of.
Okay. Well, we should talk about what the risks of the procedure are. Okay. The first thing to talk about is anytime we break the skin in a procedure, we risk infection. Okay. We do all of our procedures in a sterile environment in order to decrease that risk as much as possible. But occasionally a patient can develop an infection in the pocket here or in the actual catheter itself. The second thing we should talk about is bleeding. Now, this is a venous procedure, so there's not as much risk for bleeding as there is if we were working in arteries or higher pressure vessels. There can occasionally be more bleeding than we expect from the veins, or once in a while we may accidentally puncture an artery and cause some bleeding that way. I did check your labs today and they are normal, so I'm not too concerned about you having more than normal bleeding.
Okay.
The final thing I want to talk to you about is that occasionally, maybe several weeks down the line, this catheter may not work properly. If that were to be the case, the nurse who was delivering your chemotherapy would let you know that something's wrong with it, that it's either not injecting properly or it's not withdrawing properly. And if that's the case, then it may require an additional procedure to fix. Okay, and that doesn't happen to all of them. It's still a rare occurrence, but it can happen as well.
Okay.
Okay. That's pretty much it for the risks. Do you have any questions about anything?
No.
Okay,
Thanks.
great. Well, I guess at this point we should go ahead and go through the assessment for sedation. All right.
Okay.
The first thing I just want to ask you is, have you ever been sedated before?
No.
Okay. Have you been sick lately? Have any nasal congestion or cough or anything?
No.
Okay. Do you have a history of asthma at all?
No.
Okay. Do you snore when you sleep?
No.
Okay. And do you have any allergies?
Not that I know of.
Okay, good. And you feel like you're breathing normally right now, no trouble breathing?
No problem.
Okay, great. So what I'd like to do is, if it's okay, I just want to take a quick listen to your heart and lungs.
Okay.
So I'm going to listen to your heart first. Just breathe normally. I'm just going to listen to your heart here. Good. Now if you'll lean forward for me. Now take a deep breath with your mouth open. Good. One more. Great. Okay, you can lean back. Can you open up your mouth real wide for me? Perfect. Thanks a lot. Do you have any allergies to any medications that we should know about?
Nope.
Okay, great. Well, I have a consent form here. Before I have you sign, there's two questions I need to ask you. Okay, the first question has to do with a blood transfusion. Now, I don't anticipate that you'll need a blood transfusion. Obviously, this is a very minor procedure, but this is a standardized form that we use throughout the hospital, so I need to ask you, if we did feel it medically necessary for you to have a blood transfusion, would you have any objections to that?
No, that's fine.
Okay. And then the second question is a little bit harder and kind of a scary question. Again, it doesn't really apply to what we're talking about here, but it's a standardized question that we use on our form. It has to do with a do not resuscitate order. Do you know what that is?
Mm-hmm.
Okay. I assume just from your condition that you probably do not have a do not resuscitate order and would want us to resuscitate you. Is that correct?
Yes, please.
Okay. All right, great. Well, this form basically states that, I've gone through the procedure with you and you understand what the risks and benefits are of the procedure.
Mm-hmm.
And if you don't have any further questions, I'm going to ask for your signature so that we can proceed.
Okay.
Okay. So you would sign right there at that line right there.
Okay.
As the day progresses, it is most helpful if you stay around the PRU so that the nurses do not have to page you for each task that arises. They will appreciate it, and it will allow you to keep more on top of the patients that need to be consented. It should be noted that occasionally a patient will need to be consented in the cardiac cath lab holding area. If you do not know where this is, ask someone to show you, but it is not hard to find. One final tip is that if you are consenting a patient to have a portacath placed, it is helpful for the patient if you show them one of the demonstration models that we keep in holding. This will give the patient a better understanding of how they work as well as how they are put in. When you are in holding, you are expected to stay until at least 5 o'clock. At 5, the upper level resident on call for that night will address any further issues with patients in the PRU. This rotation is unique in the radiology residency in that a single piece of incorrect information or one wrong move in a procedure can have disastrous results. I don't mean to scare you, but I just want to reaffirm the importance of asking for help if you are not sure of something at any point in the rotation. I hope this video eases your transition into the VIR rotation. If you enjoy patient contact and doing procedures, I think you'll find this month a nice change from the rest of the radiology residency. Also, we make a big change in patients' lives up here, and it can be quite rewarding. And who knows, by the end of the month, you might consider yourself a budding interventionalist. Well, it's been fun, but if I don't want Dr. Dixon to yell at me, I better go back to work. We'll see you in the lab. This is the conference. Can we go home? Let's take out. Oh, that's the wrong one. Let's try again. God, I'm such a retard. Okay. Now this is a room. Take a look. That sucks. I hope this video eases your rotation into the VIR rotation. Let's just start this part over because I feel like a Canadian. Look at that baby. Is that orange shoes? The shoe covers are not required, but you may want to put on shoe covers to keep your shoes from getting dirty.